So with that, I want to introduce our speaker. Dr. Alexandra Minnis is a social epidemiologist with the Women's Global Health Imperative, which is a program of RTI International, and she's an assistant professor in the School of Public Health at the University of California, Berkeley, where she also holds a core faculty member in the UCSF-UCB Joint Medical Program. Allie has over 15 years' experience conducting research on the prevention of HIV, STIs, and unplanned pregnancy, both in the United States and internationally. She's conducted multiple NIH-funded research studies in San Francisco's Mission District that have examined structural factors that lead to reproductive health disparities among Latino adolescents. Her research highlighted the role of gang affiliation in reproductive health outcomes, and that's the work she's going to share with us today. She recently conducted design and feasibility research for a combined conditional cash transfer and life skills intervention in a program named Yo Puedo, or I Can. This program was delivered to social networks of close friends that promotes educational attainment and reproductive health wellness among adolescents and young adults as a strategy to promote sexual health. Her research integrates quantitative and qualitative methods and uses community-based participatory action research principles in design and implementation. So with that, Allie, are you there? Hi, Alexandra? Alexandra is the presenter, and we are recording, and unmute everyone.
The conference has been unmuted.
Okay. Alexandra, can you hear me now? Connected anymore.
Okay, Linda, can you hear me?
Yes, I can.
Okay. I apologize profusely. I went to hit my mute button and hit the headset instead, so apologies. Thank you very much for the introduction, and thank you for inviting me to join today to present this webinar. I was thinking that it was several years ago that I came down to Monterey County to the health department and presented the grand rounds on some of this work in its earlier stage. And it led to us continuing conversations and hopefully having a funded project that we might be able to initiate later this year, now that the federal government is reopened. Maybe they'll send a budget to the National Institutes of Health, and we might be lucky enough to carry forward with some of our collaboration.
Well, great. Welcome. I'm so glad you're here. That's a good thing. I'm going to go ahead and mute everyone again, so you'll hear a little recording, and then you can, I think we'll do the poll first, and then you can go ahead and get started, okay?
Perfect. Okay.
Give me 1 second.
The conference has been muted.
This is why I renamed her. She's 415. Okay. Allie, are you there?
Yes.
Okay, super. Okay, so I'd like to begin with a brief poll, and if you would be kind enough to answer the poll question so we can see who's on our call today, please mark the type of organization that you represent. So go ahead, and if you're at your computer, indicate what kind of agency you are representing. And the results are coming in. Very exciting. Let's see. Give another second for folks to poll. We also have a group here that's listening to the presentation. Well, let's just look at the preliminary results. So lots of nonprofits, public health, well represented, and we have city and county government, so that's great. Okay, with that, Ellie, I'll put your title slide up and then you can begin.
Perfect, thank you.
Okay, there we go.
Okay, so as Linda said, I'm going to present today on some research that we've been conducting in San Francisco focused on the overlap of youth violence and reproductive health. And the outline for the talk is I wanted to start with a bit of an epidemiologic overview of adolescent reproductive health in the United States. I'll keep this fairly brief, but I wanted to sort of set the backdrop for the work that we've been undertaking. And then spend most of the time looking at some of the evidence for the connection between youth violence and reproductive health outcomes here in San Francisco in the Mission District, looking at presenting findings both from quantitative and some qualitative studies that we've done, and then conclude by sharing with you the results from a randomized feasibility study that we've done of an intervention called Puedo, as Linda mentioned, that has grown out of the work that we've been doing with our community partners here in San Francisco. So as you may be well aware, teen birth rates in the United States have declined substantially over the last 2 decades, with, in the last 5 years, a 25% drop. This is clearly a remarkable shift. It's attributable to multiple factors, still up for debate, ranging from increased access to reproductive health services, delivery of comprehensive sexual health education to youth. More recent declines are hypothesized to be due to even factors such as economic recession. Yet, nonetheless, 3 in 10 girls in the United States become pregnant by age 20. It's even higher than that among racial and ethnic minorities. And the United States has one of the highest rates of teen births among all industrialized countries. So while we have much to celebrate internationally, we still have quite a bit of work to do. And here in this slide, what you can see is that the U.S. teen birth rates are down in all racial or ethnic groups, but the wide disparities persist. Most recent data suggests a sort of closing of the gap between Latino and African American youth, but nonetheless quite a bit higher than what we see for non-Hispanic whites. Overall, you can see in this slide here that the rates of teen childbearing are higher in the later teen years than in the younger teen years, as you might expect. Declines over the last 10 years are evident in both groups, yet the racial ethnic disparities persist also in both age groups, with the rates in Latino and African American teens at least twice that, or about twice that of those found in non-Hispanic whites. I wanted to turn now to sexually transmitted infections and share a few slides from CDC depicting rates of the most common STIs found in the United States with an attention toward youth. Chlamydia here is the most frequently reported bacterial STI in the U.S. There are about 1.5 million cases reported annually, though estimates of actual infections are much higher. Some estimates suggest as much as 2.8 million or more, due to a lot of these infections being asymptomatic, meaning people don't have symptoms and don't go in to receive testing and treatment. Most new STIs occur in adolescents and young adults. And you can see here that higher rates in young women relative to young men, and really quite high rates in the late teen years and early 20s. There are a number of explanations for why we might see the imbalance between women and men, with much higher rates seen in women. In part, this is likely due to an artifact of testing. That is, young women are more likely to seek services or to access services where they would be receiving testing relative to adolescent males. For those of you working with adolescent males, you know that they're not that likely to go in and seek reproductive health services. That's a challenge for sure, engaging teen males and thinking about this aspect of their health. But there are also physiologic reasons for the disparity, as well as some more social sort of partnership-related patterns that might contribute to the rates that are observed here. I wanted to also show that as with pregnancy, we see racial ethnic disparities in rates of chlamydia infection, with African Americans having the highest rates. And given our focus today on community violence and reproductive health, I wanted to draw your attention to these national data as well that highlight high rates of chlamydia among populations in juvenile correction facilities. Even at the younger teen ages, here you see a high prevalence of chlamydia. And then these are the same data, similar data for adults. Also note the high rates among those less than 20 years old, as well as those in the 24-year age group. Just a quick glimpse at two other common sexually transmitted infections. The first one is HPV, or human papillomavirus, for which we now have an effective vaccine for the most common types in the United States here. The prevalence overall is quite high, so that you can see it's about 20% of teens, or a little over 20%, in teen females, with the peak in women aged 20 to 24. Hopefully we'll see more widespread adoption of the HPV vaccine, and that would result in a tremendous shift in the prevalence that we'd see when we conduct a national survey like this. Vaccine uptake right now for the full doses is about 30%. So we have work to do in that area as well. So that's not the focus today. And then before leaving my epidemiologic background, I wanted to also just make a comment about herpes, which is another very common sexually transmitted infection. Here we have national data comparing whites and blacks by age group. And you can see that actually it presents an opportunity for prevention with teens, where the rates remain quite low during the teen years, and we really see a jump in the 20s. So continued effort to try to minimize the acquisition of infection is warranted. I'd like to turn back to California for a minute, where we have 1 in 8 U.S. adolescents reside here in our state. And our teen birth and STI data do look quite similar to the national estimates in terms of age distributions and racial ethnic disparities, but because of the demographic composition of our state, our need for emphasis on Latina adolescents in particular is quite profound. And as presented here, we see that Latinas maintain the highest teen birth rate in California, accounting for about half of our population, yet nearly 3/4 of teen births in 2010, and it's similar for 2011. The Latina teen birth rate is 3.4 times higher than that for non-Latino whites. And things are similar in terms of the STI rates, where they're 3 times higher. This is for our common STIs like chlamydia, those that are reportable for females, and 2 times higher for males than for non-Latino whites. And here are the most recent data for the state that were released this summer, showing the teen birth rates by race ethnicity over the last 4 years. And you see off to the right here, this is just the same point now made visually, that yes, we've had tremendous declines, there's a lot to celebrate, but there's still more work to be done to address this issue. So given all of this, what are some of the viable directions for epidemiologic research that will inform programmatic and policy interventions? And here is a graphic that's very familiar to many of you, because many social epidemiologists and those working in prevention adopt what we call the social ecological framework. I've depicted it here, and it looks lopped off in the top one there, in its simplest form. Recognizing essentially that individuals are embedded in and shaped by their interpersonal relationships with peers, with family, with partners if you're focused on reproductive health, that they reside in community structures and opportunities shape the individual behaviors and outcomes, and ultimately that societal and policy factors, which might be things like immigration, cultural norms, healthcare structures, will influence individual outcomes. And in the realm of reproductive health, the persistent epidemics of sexually transmitted infections and unintended pregnancy among youth have made clear that the individual level prevention approaches alone will be insufficient to improve sexual health, to achieve the goals that are set nationally for us. And these are the things like condom use, reductions in numbers of partners. Of course, they're important, but that's not going to solve our problems and get us where we need to be. It's clear, sexually transmitted infections and pregnancy occur within partnerships. Behavioral and gender norms are shaped and reinforced by social networks. contraceptive practices are affected by access to high-quality, confidential reproductive health care, with immigration and the legal climate around provision of services for immigrants influencing people's access. And thinking again in the sort of societal policy realm, socioeconomic resources certainly shape perceptions regarding future opportunities. So we began our multi-phase research program in San Francisco's Mission District in 2001. Over this time, we've examined social environment influences on adolescent reproductive health through what's a prospective cohort study, meaning that we enrolled people and followed them over time with about 555 teens. We've also done several qualitative add-on ancillary studies that were designed to address specific questions that emerged through our work. One, Mi Cuento, that focused on relationships I'll be presenting on today. And most recently, we have designed an intervention that we evaluated for feasibility, Puedo. So actually, I'll be presenting on several of these projects. Our research has taken place in San Francisco's Mission District, which is home to the city's largest concentration of Latinos. About 60% of the youth who reside in the Mission are Latino. And the neighborhood is characterized by vibrant ethnic pride, continued arrival of new immigrants from Mexico and Central America, and also substantial economic and health disparities. And so while the residents are comprised of about 60% Latino youth, the schools and the social activities that take place there, it's really a draw for Latino youth throughout the city and even in the San Francisco Bay Area. I wanted to note that up to this juncture in the talk, I focused exclusively on reproductive health, which was an intentional choice on my part because I wanted to frame the work from the same perspective with which we had approached thinking about pregnancy and STI prevention in our own work. However, we began to identify the social environment influences that would ultimately become a focus of the research. It was evident from the outset that we needed to pay attention to youth violence. Street gangs shaped mobility, a sense of safety, and the risk environment in which sexual partnerships are formed in the neighborhood. One of my first tasks in designing the prospective cohort study was to think about the recruitment plan and really design how is it that we were going to accomplish our goal of enrolling over 550 young people into a 2-year study. And we had determined that we would use a community-based approach because that's where the youth were, hanging out in the streets and not at home waiting to answer a phone call or a knock at the front door. And we also didn't want to do a school-based study with this age group because there's a lot of truancy and felt that we wanted to make sure we were also including out-of-school youth in a fairly substantial way. Excuse me. So we started by convening focus groups of youth, and I wanted to draw your attention to this hand-drawn neighborhood map in the top left corner of your screen. We asked youth to draw maps of their neighborhood, and this one was drawn by a teen male attending Mission High School. It depicts one city block, his neighborhood, replete with liquor stores, drug sales, a drive-by shooting, and gang tags. And it really conveyed profoundly to me the importance of considering how the social environment, the economic environment, the presence of youth violence really shaped reproductive health behavior and prompted us to pursue this more actively in our work. Now, of course, youth violence in the U.S., many of you are working in this area as well. We know that it's widespread, homicide being the second leading cause of death among youth aged 15 to 24, that 1/3 of law enforcement agencies in the United States report youth gang problems, and that nearly half of high school students and a substantial proportion of middle school students report their students at their school who consider themselves in gangs. So it wasn't a complete surprise, but coming really from the reproductive health perspective, I think we were focused more on things tied to ethnicity, to immigration, to the economics, poverty of the neighborhood, and had to shift our focus a little bit as a result of some of our preliminary work. The first study that I'll be presenting on was a prospective cohort study that we conducted. It had two primary goals. One was really framed around social and sexual networks, who's connected to whom, and how they influence pregnancy and sexually transmitted infections among Mission District youth. And then to look more deeply at how the neighborhood social environment influenced how the networks themselves formed and were composed and shaped people's risk, really believing that the environment in which youth are spending time is influencing their behaviors and outcomes. A bit of background on the participants themselves. I didn't put sociodemographic stuff up here, but essentially a third of them were born outside the United States, and most were in school, at least partially. About 80% were in school. And here you can see that there is pretty high experience of pregnancy history in a group of 14 to 19-year-olds. Among the sexually active, a quarter of females and males had either been or gotten someone pregnant. And over time, the incidence measure of what we observed over the 2 years, we had 72 pregnancies among 65 people, young women. And so that, again, is about a quarter of the sexually active females becoming pregnant over the 2 years. Chlamydia rates were lower than what we would see in San Francisco anyway in an African American population, but about 5% tested positive for chlamydia. I wanted to make a comment about pregnancy intentions because there are a lot of assumptions about the degree to which particularly Latina youth may want or desire pregnancy and how that affects the outcomes. Over the 2 years, we asked people at every visit, which took place every 6 months, whether or not, several questions about their pregnancy intentions. And this one in particular focused on wantedness. Would you like to become pregnant in the next 6 months? Would your partner want you to become pregnant? And 80% of participants consistently reported no desire for pregnancy over the 2 years. Nonetheless, more than 70% of the pregnancies, in fact it's almost 75%, occurred in girls who stated they definitely did not want to become pregnant. So that's not to say that there was no pregnancy wantedness, but by and large, I mean, young people, males and females alike, and this is very consistent in the work we do, are not wanting to have children. And this table presents a combined measure of the participants' report of their own wantedness or their desire for pregnancy, and also their partners. And so the first row, where it says neither want, means the young woman in the case of the first column, or the young man who was in the study in the second column, reported that they didn't want to get pregnant in the next 6 months and their partner didn't want them to. So you can see that's at least about 70% of the population. There were about 15% who reported that their partner wanted, but they didn't. The reverse situation was fairly uncommon, 3% and 4%, that the respondent wanted, but that her partner didn't, so there was a mismatch. And then you can see that it's about 10% that both expressed some wantedness for pregnancy. One thing I would note here is that we were interested to know, are there differences between what the females say and what the males say? And actually, no. There really weren't any differences in terms of males and females' expression of pregnancy wantedness and sort of the degree to which they were in a relationship where there was agreement or disagreement about this. Okay. And interestingly, if we looked at the relationship between this factor, the wantedness, or the measure of pregnancy intention, and what actually took place subsequently, we find that while indeed both people wanting to become pregnant was associated with a later pregnancy, the other factor, which is an important one I think to focus in on from a prevention perspective, it was this mismatch. It was the partner wanting where the participant didn't, that those people had the highest chance of becoming pregnant, the highest odds later on of a pregnancy. Now to look sort of straight on at the gang affiliation and sexual risk analyses. So the table here, the graph, depicts the proportion of participants who they themselves reported being gang affiliated or they had close friends who were gang affiliated. And you can see that it wasn't that common for youth to report to us directly that they were. A little under 10% of enrollment, and it inched over 10% over time. We believe this is an underreport because many people said, yes, but don't write it down. Youth, when you do research with youth or work with youth, you may know that sometimes it's effective to ask them, well, what are their friends doing? Because they're more likely to tell you what their friends are up to than what they are themselves. And so you can see that it was fairly common here. 40% of participants reporting having close friends who were gang affiliated. 20% of the females, that's not included here in the graph, but 20% of the females reported that their partner was in a gang. So this was fairly common. We were interested in looking at two questions. First of all, was there a relationship between having a partner in a gang and increased pregnancy risk? And we chose pregnancy because it was our more common outcome than the chlamydia, but indicating unprotected sex, obviously, and an outcome that most of the youth in the study did not want at this time in their lives. And you can see that having a male partner in a gang increased pregnancy risk by 90%. The hazard ratio is the effect estimate from our statistical analysis. If you're not a statistics person, you can sort of ignore that, but it's the 90% increase. And this is significant from a statistical perspective. What we also were really interested in, though, is, okay, so we established this relationship, but what accounts for it? And so mediators, looking at mediators, the factors that are sort of on that causal pathway, what's happening between having a partner in a gang and actually the occurrence of a pregnancy that might explain why. And so we considered a number of partnership characteristics. We also looked at contraceptive use patterns and pregnancy intention. And two things really stood out. The first was having a partner in detention. There clearly was a heightened importance of having a baby with an incarcerated partner. And this was a quantitative study at this point, so we didn't have a lot of rich explanations as to why. But there's evidence in the literature and also what we had learned through our own work that there's clearly a disruption of relationships that takes place with detention. There's the formation of concurrent partnerships, people having other outside partners, and there are substantial implications in terms of sexually transmitted infections. The second thing that really stood out was the issue of pregnancy intentions, which I alluded to when I presented that pregnancy wantedness slide. That the male partner's desire for pregnancy exerted a strong influence on the relationship between gang membership and pregnancy. And the potential explanations that we offered in consultation with some of our community advisors and youth participants were really fell into sort of three categories: social pressures to have a baby, perceptions that pregnancy strengthened the relationship commitment, and decreased power to negotiate method use, increasing the influence of partners' pregnancy desires. And it's really the case we know, from other national studies that their gender roles are relevant in all relationships, not just gang-affiliated relationships. Who is most likely, this is from a recent national survey done by the National Campaign to Prevent Teen and Unplanned Pregnancy, who is most likely to begin conversations about using birth control. And the onus seems to fall on girls, as reported by teen girls as well as teen boys. And so in a relationship where there's compromised power and a sense of opportunity to have these kinds of conversations, it may be that the conversations about birth control don't in fact take place. I wanted to just note this other study that was pretty interesting that explored some of the findings from the work that we had done and tried to get into the narratives behind these relationships. And so I put the citation up here if you're interested in reading more about it. But this is a qualitative study, so a very different flavor, 20 life history interviews with gang-affiliated young women in Los Angeles. And the findings really underscored things related to sexual coercion, strong male desire for pregnancy, physical and sexual violence, and a history of family violence is really quite influential on pregnancy occurrence in the young women participating in that study. So I'll turn now to Mi Cuento, which was a qualitative study that we conducted after having finished our quantitative work and taken a pause with some of our research in the neighborhood, really to kind of look more at this issue of what was happening in relationships. And we wanted to explore, and sort of what I'll present today focuses mostly on the gang-related partnerships and how that influences people's decision-making around contraception and the potential risk for reproductive health outcomes. But there's another dimension to this study, which is also really trying to explore assets and what are the positive dimensions to relationships that youth are trying to search for an ideal, to have something that supports them in achieving their goals. Okay, there we go. So as I said, the objectives here were really to characterize relationship formation and ideals, and we were looking more broadly at social factors that influence relationship fidelity and risk for STIs and unplanned pregnancy. So this was a study with 33 in-depth interviews. People were interviewed one-on-one in Spanish or in English, their choice. And we included both male and female youth. And they had to currently be in a relationship. We didn't stipulate how long it needed to be, but sorry for the sirens outside. And we included first 1.5 and second generation youth. The first generation youth being defined as youth who'd come here from middle school aged on, so as a teenager, whereas 1.5 moved to the U.S. during childhood, prior to adolescence. About half of our sample was female. 17 and a half years old was the mean age. And because of our design, we sort of ensured that we had half of our sample of participants coming from Mexico or Central America. We really wanted to explore dimensions related to immigration and adaptation here in the U.S. And the current relationship mean and median, that was about half a year, 4 to 8 months. We presented, because of our quantitative work, we were interested in really looking at this issue of multiple partnerships and overlapping partnerships, because we had a whole other piece that I didn't present, which was really looking at networks and trying to identify what are the patterns of partnering, and can you identify the high-risk ones and who's in those high-risk groups, and try to focus and target your intervention there and really work to do more focused outreach as opposed to sort of broad messaging to young people in the neighborhood. So we presented youth with this relationship norm and asked them whether they agreed or disagreed with it, and that was many mission youth in a relationship are also seeing someone on the side. And there was near universal agreement with this. People sort of laughed and said, well, of course. And they talked about maybe 3 primary concurrency patterns. Concurrency, for those of you not in the networks world, basically means partnerships that overlap in time. So rather than sequential partnerships, these are you have one main partner and you have others that you're seeing either on a one-night stand sort of deal or more often than that. So the patterns were really cheating, main girl with friends with benefits on the side, overlapping partnerships, sort of hedging your bets and initiating new relationships before ending existing ones, and partnerships between serial breakups with a main partner. As one youth commented, relationships in this neighborhood are messy. And I think it's also no surprise that there was this widespread belief about infidelity. I mean, it's all over the news that and these are active users of social media, that there's a lot of cheating. So if you just Google infidelity and social networking, you'll get tons of links, and there are websites that help you find out, is your partner cheating? And there was this really strong theme in talking with the youth of distrust, and wanting an ideal where you had a trusting relationship, but finding it very hard to achieve, and doing kind of a lot of elaborate things to ensure that people were honest with each other. Some of the motivations expressed for concurrency included secrecy, the thrill of hiding something, and the apparent ease of being able to just hit it and quit it and not talk to her ever again. Machismo was brought up by some, this sort of prestige of having lots of partners means you're better than the next guy and all that. It's a competition to see who has the most. Multiple partners were pursued concurrently to ensure a viable relationship is available. There was boredom with a single partner. There's so many choices, and men get bored with the same thing, so it was really kind of accepted by both males and females that this was a reality and reasonable. Fidelity was relevant only in the context of marriage. And then there was also a fair bit of concurrency of hooking up with other partners regarded as revenge for known, suspected, or even preemptive cheating, cheat before he does. In the interviews with young males, it was quite clear that street gangs shaped partnership patterns for many of them, particularly those who were more affiliated. There was a sense that there was really limited time for relationships because of obligations to the gang first and foremost. Remarks such as, when you're in a gang, the first is the homies. There was disinterest and commitment to avoid the emotional vulnerability given the emotional demands of street life. She told me she wanted to be more than like fringe benefits. And I told her, well, I don't really know, because those relationships, they don't be lasting, and when they do, they feel bad. Multiple partners were also regarded as bringing status. This came up earlier. This was really a theme across all the male interviews, I would say, but then more strongly expressed for those who had some kind of gang affiliation. You got more gang, you got more reputation, pardon me. So thinking then about the link between, what it might mean for partnerships and actually the reproductive health implications. One female participant remarked that I never had a partner who was a gang member, but I've seen a lot of my girlfriends who have, and they wind up pregnant or their boyfriends are in jail, and the girls are left with nothing. In trying to understand this, people discussed issues around social prestige of the gang-affiliated partner, being the main partner or a good girl versus the hood rat. Frequent alcohol or drug use being tied to unprotected sex and to casual sex. And the issue of alcohol use in this community anyway is really prominent. A lot of liquor stores, from another sort of ecological perspective, your youth can walk into liquor stores and buy and be given a cup to prepare their own mixed drink right there outside on the sidewalk. Pregnancy was also adopted as a strategy to strengthen the relationship commitment and draw a partner away from the street. I said, you want to, and this is a young male who expressed this as well. I said, you want me to get you pregnant? Then you can graduate at school and I'll be able to work. I don't plan on going nowhere unless I get killed, and I can't control that. It's a lifestyle. I think also kind of sort of inverting the association and thinking about the partnership implications on violence and safety, switching the arrows the other way. It was very clear as well that just the exposure to violence through partnerships, the fears of safety, present the public health challenges and personal well-being challenges for young people. The fears regarding safety, every time you leave your partner, is that the last time you're going to see him? You can imagine that's emotionally challenging. It can also have implications then for how people express intimacy sexually with one another. Of being affiliated by association, being exposed to violence that you otherwise would not experience, that it's dangerous when you're out with your family and people start to recognize you. If you beat up one of theirs, or if they beat you up, they will recognize you. I also wanted to, before moving off of the Mi Cuento findings, though, I wanted to just comment that by and large, these young people didn't want to have children, and that they really had dreams, many of them. And I think, expressed by this quote here, this young person desired to go on to graduate school and not wanted a baby until she was 32. This isn't a typical case, but despite living in a neighborhood where there's a lot of things constraining choices, there's still young people who are really aiming to finish high school and go to college and have a career and have a planned pregnancy when they're ready. And people described positive partner influences on their future plans. If you just look down the first column, the kinds of categories of things, discussion of future plans and shared goals for college and career. 24 out of the 33 described concrete situations when this had occurred. Relationships starting out as friends. Clear intentions expressed to one another that they didn't want to be a dad or a mom right now, so the young people are having conversations with each other in their relationships about this. They're not ready, they're trying to live their life first. A recognition that they were dedicated to school. But when presented with a norm, most mission youth plan to go to college, people were really split on this. And I think that what comes through is that they were split because of the constraints. They can't go because they don't have the money, because they're undocumented, or because their family doesn't support them. They don't see a future. If you were undocumented, why the hell would you go to college? Another person remarked, I hope they do. I want all youth to plan to go to college. Like I know a lot of my mission youth, they're planning on shooting somebody, or they're planning on getting shot, or they're planning how are they going to eat. Like there's these little homies that are 15, 16, don't have nobody at their house. How can you expect them to go to school the next day, let alone go to college? So I'm thinking about synthesizing findings that are, on the one hand, presenting quite a few different social influences, and you need to act in a certain direction. What do you do? And there's a sort of picking your point of intervention is a place to start thinking about it. And this sort of simple graphic here, Judy Auerbach put forward in the context of HIV, but it's relevant, I think, as well here, conceptualizing social drivers from very narrow. We've tended to do a lot of things on the right-hand side of this arrow, the classic behavior change, and really try to pushing away from that to address intermediate constraining or enabling structures. There are a lot of really good family-based interventions, I think, that intervene here. But there's less that's been developed and evaluated and really less known about how to intervene at the structural change level. And certainly its social change is difficult too when you talk about really trying to shift norms. So I will present a bit here now on the Puedo study that we've done, which grew out of the work that I've presented to you that we've been conducting. And it's really a study that aims to, it's an intervention that aims to combine conditional cash transfer payments with life skills education with the goal of promoting sexual health among youth. And the conditional cash transfers, and we could give a whole presentation on that, but it's a concept that's been used quite a bit internationally. Mexico has really the sort of flagship program, Oportunidades, where you incentivize with cash payments certain health behaviors. There they promoted, or it can be educational behaviors, so sending your female children to school, coming in and having your children vaccinated, things like that. It's been applied less often in the United States as a strategy. There was a big program in New York modeled after the Mexico one that Bloomberg conducted, Opportunity NYC. And anyway, so we decided here to take that model and see how would it work in a community focused around the improvements to sexual health here with adolescents. So sort of building on lessons learned from past conditional cash transfer interventions, and our own work in this neighborhood, we really wanted to deliver the intervention to small social networks of close friends, recognizing among adolescents that peer groups are influential. We tailored the intervention so that the educational and job training goals were selected by study participants themselves, rather than us prescribing, go to school. It was more tailored. Part of it, my opinion, that people go to school, but they may be off the streets, but not necessarily moving toward even graduating just because they're there. Participation and performance-based incentives were offered, meaning some of the payments were for just coming and doing something, and others were actually delivering a finished product. And the incentives were paid to youth directly. The conceptual model, on the left-hand side of this logic model, you can see the conditional cash transfer goals included educational, vocational training, reproductive health, wellness, clinic visits. So we didn't incentivize using birth control. What we incentivized was going to a clinic and having a reproductive health visit and letting the clinician and the participant decide what their needs were. And then we had life skills sessions. We were focused here on looking at short-term and intermediate outcomes, so really looking at issues around self-efficacy, that sort of thing. We weren't powered to look at pregnancy, in the short-term study, but we were interested in focusing on the social environment. Did we see any evidence of change in how people spent their time, who they hung out with, that sort of thing, and also some of their individual behaviors, with the ultimate goal of looking at long-term outcomes. To give you a flavor, some of the life skills advocacy theme was threaded throughout. And so we had youth, understand what is the concept of advocacy, and one of the weeks they made posters to hang up in their schools or community. But this transfer then, how do you advocate for yourself when you go to a clinic, and how do you advocate for yourself when it's time to fill out a job application? And the idea was that youth are supporting each other, and it wasn't delivered by a trainer to tell everyone how to do everything, but that they were sort of building capacity within their social network. In the interest of time, I'm going to skip this slide here. So we included male and female youth aged 16 to 21 and same-aged members of their social network. And what I'm going to focus here in the few minutes that I have is really on the feasibility study, not so much on the design phase, though we did undertake a design phase where we used some techniques from environmental economics, which are actually quite interesting to me as an epidemiologist, where we basically said, we wanted to figure out what do you incentivize. You don't want to incentivize for $20 people to do something they're going to do anyway, because we have limited resources. And you want the dollar amount to be reasonable so that it actually motivates the behavior. And our thinking here, this was not a poverty alleviation program. We didn't have thousands of dollars to dispense. Youth could earn up to $200 over 6 months. So the idea was really this was a nudge. Or it was also a destigmatizing amount. So it's not very cool as a guy to go to a clinic, but you can always say, hey, I'm going because I got $20. That's the idea. So our feasibility questions focused on social network recruitment and randomization. Could we do this? Would people come and participate? And were there any negative implications of giving these reward payments to youth directly? There were people who were concerned about giving out cash to youth, even though the amount was about $200. So we needed to, before doing anything larger, we needed to answer these questions. And then we looked at evidence of effects on some intermediate outcomes that we know are associated with adolescent sexual health. Here's a map of the neighborhood. Now, instead of a hand-drawn, it's another one that was developed in partnership with our community board members. We recruited from various venues, and because of the gang territorial, if you want to find youth in the Soreño side, you need to go there. We also recruited from some schools. We had school partners and community agency partners. And you can see quickly in terms of our background participants, about a third were foreign-born. Over half would be considered low socioeconomic status, extremely low, based on low maternal education and use of social services. If we look at a combined measure of sort of risk based on socioeconomic risk and also behavioral risk, over 90% of our sample would be considered high risk as we were defining it. The social network recruitment went very well. What we found is that people didn't recruit people who were riskier than themselves, which is often what happens when you do a social network study. They think, oh, this person would be really good for this study. Let me go recruit them. We basically were finding that we got risky people from the outset. That's what the slide communicates. In terms of uptake, people didn't come and participate and do everything. Those who work at the programmatic level and agencies thought, okay, you guys did well, you've got a lot of participation. Me as a researcher, I wanted to see more. So we've made some tweaks to the design. Basically, people participated, but the sessions were difficult. So we've decided to collapse them into longer workshops. This is the main slide of findings here, looking at the effects on intermediate outcomes. These are odds ratios, which basically, if they're above 1, they show an increase of something. If they're below 1, they show a decrease. So just to focus on this first column where it says ITT, the intent to treat analysis, that means if you were randomized to get the intervention or you were randomized to just do your standard services in the community, we made a comparison, ignoring whether or not the intervention people ever did anything for the intervention or earned any money. And what we find is that the intervention people were half as likely, the 0.5, to hang out on the street, to report being sexually active in the last 6 months. Those with the asterisks are significant associations. The second column is one that gives a little more attention to, did people actually do anything for the intervention? And it's called a per protocol analysis. And so these are the people who came to at least 3 sessions, and completed at least one goal for which they were able to bring the paperwork to get the payment. And you can see here that we show things are heading in the right direction. They're below 1, the 0.4. People had a lower odds of reporting that they had close friends at the end of 6 months who were gang affiliated, close friends who'd been incarcerated. Does this mean they changed who their close friends were? Who knows? We don't know exactly the mechanisms underlying this, but there was a general sense that people were spending less time, hanging out on the street and with people who were some of the more higher risk youth in the neighborhood. Interestingly, they also reported that they were less likely to use alcohol and marijuana at the 6-month mark after having been in the intervention. So in terms of our next steps, we felt that we have enough evidence of feasibility to go forward with this. We certainly have made some changes to our model, which if anyone's interested, I'm happy to talk about or email with you later on. And we've, unfortunately, due to the government shutdown, our proposal is supposed to be reviewed on Monday. And so anyway, we submitted it in June. Those of you who get federal money know that it takes a while to get reviewed. So I have no idea when it will be reviewed. I'm sure it will be at some point. But we really look forward to, we've expanded this to the proposal is to do it in 2 neighborhoods in San Francisco with quite a large number of youth, with the study powered to look at effects on pregnancy and 2 sexually transmitted infections. I think I'll pause there. I haven't left more than just about 5 minutes for questions. And of course, there are many people to thank when you're doing multiple projects like this in collaboration. So Linda, I don't know if there are people who've written in questions while we've been talking that you'd like to put.
If you have a question, please write it, type it in the chat box in the lower left corner. It doesn't work well to, I'm actually unable to unmute individuals because you're only recognized by your phone number. So please take a moment. If you have a question for Dr. Minnis, please type it in the chat section, which is in the lower left corner. And I'll ask our audience, our live audience, do you all have any questions off the top of your head? Well, just sort of to get the conversation rolling, we are very much, I would say constrained, but limited to using evidence-based programs, classes. We offer Cuídate and for teen pregnancy prevention. But I'm wondering if there's an opportunity to to work with social networks to recruit young people and their friends for classes.
I think it's an interesting idea. But what we didn't measure here, but what I would like to look at is, there are other sort of theories of intervention that have been used in HIV, for example, where the whole concept of diffusion, where you don't have to reach everyone. Maybe it's almost like herd immunity through vaccination. You just need to reach a core group of people, and then they'll disseminate the ideas to others, and maybe you'll even shift norms. Where it's quite normative to, have children in your teen years or not to graduate from high school. What you'd like to see is, waiting to have children until it's the right time for you instead of something that happens accidentally, and then you're sort of living with the consequences of it. So it's an interesting thought that, I don't think those interventions that are on the CDC approved list specify, how do you engage your participants. So maybe it's an interesting thought to kind of think about how you actually recruit people to participate, and could you actually achieve some greater effects. You may still be delivering that curriculum, but you've got the other ways in which people can support each other. You could build other things into it. So
that's very interesting. I think your emphasis on social networks and looking at the socio-ecological model on the social level is really fascinating, and so much of a turnaround from working with individuals. I'm looking at a public health nurse who works one individual at a time, and maybe isn't aware of, doesn't have access to, doesn't know about that individual's network and the pressure or the impact that network is having on his or her, more often than not her, behaviors.
Absolutely. Yeah. Yeah, I don't know. It's very hard. I worked a bit with some grantees, federal grantees, who were residing in states where the states had declined federal money because it required that you do more than abstinence-only education.
Yeah.
And so anyways, there was a select group of people working in political environments where, it's Texas and North Dakota and some of these places where it's very hard to do anything. But yeah, they really felt stuck, having to pick programs off these lists, and yet knowing that there are a lot of underlying structural political environment factors that are quite influential on even people's ability to access contraception, much less, adopt other prevention behaviors. So.
Very interesting. Maybe take 1 minute. You've kind of alluded to it, Dr. Minnis, but if you could perhaps briefly summarize the research project that you've proposed to NIH for Salinas.
Sure. Well, it's an exciting opportunity, and really it's something that, for those of you who haven't talked with Linda about it in Salinas, it's quite an example of developing something in collaboration where Linda approached me and felt that there really needed to be good sort of public health epidemiologic data on, the factors that contributing to the joint outcomes of youth violence and teen pregnancy in Salinas and in Monterey County. And so we designed a prospective cohort study that's kind of mixed methods, meaning that it has some of a flavor of what I presented to you today. Some qualitative pieces in the design phase at the beginning, and then over time we would also have some in-depth interviews with youth. But the main piece of it would be to really look at this transition between 8th grade or middle school and high school. There's quite a bit of work done on the middle school years and on the high school years, but that transition is really when a lot of the risk is adopted. And what can we do to intervene to mitigate that during that period, and to try to look at some of the unique features of a more agriculture-based community, and the economic issues there, the employment. Even the family interventions that have been designed in urban settings may not be appropriate for a community like Salinas. And so we've used the social ecological approach and identified factors at 3 different levels. Of course, the individual stuff is easy, and we'll still look at it. But what about the relationships with partners and with friends and family? But really focus mostly on partners, and then those structural things, the cultural and gender norms, and with the eye toward, at the end of having collected the information, we'll have a really good sense not only of risk but also of protective factors. What are the things that could really be enhanced, that are innate in Salinas and that are normative, that would lead to better outcomes, that might become a focal point for interventions, to complement the interventions that are being done that are individually based, that are the ways to get funding from places like CDC, but what could be done at the community level that might actually change the environment in which people are making decisions and meeting partners. Anyway, so we hope to, it was scored well, but nothing's certain until you get notification. So.
That's hard, yeah, and especially with things being such a mess.
I know.
That's really an exciting possibility, and one that we are really keeping our fingers crossed for. Again, the whole notion of who you hang out with, choosing friends that are not at such high risk, and how we can influence some of those things, in addition to, as you say, the individual behavior changes, which we focus on strongly. So,
yeah.
Well, I can't thank you enough.
Okay, sure. And most people can probably see, but I did put my email, because I had meant to make a slide with my email, but if anyone wants to be in touch afterwards, or you walk away and you wish you'd ask something, please feel free to be in touch. So.
That's great, and this has been recorded, so if you have, for our listening audience, if you have friends or colleagues who might like to listen and watch the webinar later on, I'll send out an email that will have the link to the recorded session for those who weren't able to join us. So with that, Dr. Minnis, Ali, I want to thank you so very much, and we really appreciated your presentation today. And to our listening audience, thank you so much for joining us. Have a great day.